William Dombi is the Vice President for Law with the National Association for Home Care and Hospice. He specializes in legal, legislative, and regulatory advocacy on behalf of patients and providers of the home health and hospice care. He has more than 40 years of legal, legislative, and regulatory expertise and is one of the leading health policy experts in the country. William.
Well, you guys are going to regret that I'm here. When I wake up before one of these presentations, I have to try to figure out, do I bring the optimistic view, the pessimistic view, or the one in between? Well, I'm going to probably go in between, but honestly, it's going to be a tough ride that I want to take you on. Here's how I'll sum it up if any of you want to leave early. Congress says, we really love you. And the state Medicaid programs say, we really love you. And the Veterans Administration, another big payer, says, we really love you. But, between you and a B-1 bomber, between you and infrastructure, between you and anything else, we're probably going to spend our money elsewhere. Okay, but we really see you as the solution to everything that is creating pressures within healthcare. We all know the demographics, the demand growing for services for particularly senior citizens and elderly. I say that hesitantly because I get a discount at the movies now. I finally was willing to bite the bullet and accept the senior ticket because it's frankly, it's almost $3 off. Now I'm building my retirement fund. But that aspect of priorities, this country has a lot of priorities, and the seniors and those with persons with disabilities are absolutely a priority, and they do see the demand for healthcare services rising in all manners of delivery of services, but in many, many ways they see care in the community as the best solution, particularly for individuals with chronic illnesses. So we sit there and we're shining stars, we're welcome all the time, and then there's the but. But we don't have money to pay for it. Now, on the regulatory side, because in fact, we're not a society run by Congress anymore. It's a regulatory state, at least from the world that we have it. And that's not just the fact that President Obama has used executive orders to do all kinds of things that Congress says that you can't do. It's because there is a lot of discretion that the laws give to these administrative agencies to bring them into implementation. And the main administrative agency, at least that we deal with so much of the time, is the Centers for Medicare and Medicaid Services. The fact that CMS has one M in the acronym but two Medicare and Medicaid in the mix tells you what kind of difficulty we'll all have to begin with. We can credit Tom Scully, late of CMS administrator position, for that. On our payroll, actually, we pay his firm, Alston Bird, for his help, and Senator Bob Doles and a few other people to help us out in our efforts. But on the regulatory state side of it, they say, we don't love home care because, you see, there can't be any emotional attachment to any health care from the regulator's side. We think home care is good. We think home care is very valuable, whether it's hospice, home health, or some other form of home and community-based services. And then the big but comes in. The big but today is, but we want to watch your quality of care. We are concerned about the program integrity of home care and hospice services. We think we're paying you too much, and we think that we're not getting the best bargain that we can from a quality value perspective. All of these buts translate into many, many kinds of activities generally found on the pages of the Federal Register. This is, in my mind, in all of the years that I've been doing it, probably the most stressful time for home care and hospice organizations from a regulatory standpoint. And Michigan, you are one of the target states where that stress is going to be enhanced. And this afternoon, I'll be on a session with Illinois providers to talk about something that's coming into Michigan, unless we can succeed, coming into Michigan January 1st next year, called pre-claim review. Imagine if all of your third-party payors said, we want to fully examine your claim, your paperwork, the bona fides on the merits and everything else before we agree to pay. But it's going to take us quite a while to do that. And we're not sure we have all the resources to do it, but we'll tell you we do. And then you start seeing the results of it. Illinois is where it's happening now, has been in this since August 1st. And only within the last week have we seen actual determinations made on what they call pre-claim review. They don't want to call it prior authorization because it's not, they say. Even though you can't submit a claim and get paid if you don't have a favorable pre-claim review. So we're not sure how they can differentiate between the two, but the claim determinations that are coming out of Palmetto Government Benefits Administration, PGBA, as we fondly use the acronym, are, in our minds, a disaster in the making. We are seeing 8 out of 10 claims rejected. Every single episode of Medicare Home Health has to go through this. So this is not 8 out of 10 on a small little group of cases that have been randomly audited. This is every single one of them. From an operational perspective, it's pretty clear they don't know what they're doing. I mean, provider will get a claim determination that says, we're not going to give you an affirmation. They don't call it approval. They call it affirmation and non-affirmation. They're coming up with words, of course. We're not going to give you an affirmation because you didn't submit documentation. You didn't submit the plan of treatment. You didn't submit the physician certification. You didn't submit the physician face-to-face encounter documentation. You didn't submit any documentation. And the provider knows that they did. And then they go on and they say, in addition, the documentation doesn't demonstrate a medical need for the services. Well, if there was no documentation, what documentation did they review to determine it wasn't medically necessary? And the same with homebound. So they end up with 50 different answers as to why they're rejecting the claim. Starting with no paperwork has ever been submitted, but the paperwork is there. In order to solve the paperwork problem now, the geniuses at the Centers for Medicare and Medicaid Services in Baltimore, where this project was born, have said, we recommend that you not use the electronic portal to the contractor, instead fax the documents in. You know, you're probably asking yourself, where is my fax machine? You know, I mean, how long ago was it that you were faxing documents into someplace? I don't know, maybe some payers still do that, but I thought we've been in an electronic world for a long time. You know, and maybe if you even have a fax, you hope it's a plain paper one rather than one of those thermal faxes. You break out, you cover it, take the dust off. Now, that was a great suggestion, right? I mean, it made no sense on the surface, but then the contractor had a limit as to what they could take on faxes. And if you couldn't get your entire record in one fax, they couldn't accept it, and then they couldn't take pieces and combine the two. So, but resources become the big issue on this too. Medicare has reviewed about 30,000 claims in what complex medical review on an annual basis nationally. The 5 states they selected will have 1 million claims that have to be reviewed. Yeah, and unless you're looking for a job to move to South Carolina at PGBA to do claims reviews, we don't see any new resources. Instead, they're reassigning their medical review resources. The people at CMS think it will take a home health agency 5 to 10 minutes to assemble the record. It is taking 2.5 hours to assemble a record that then is lost when it gets there. So, I mean, we are talking, you know, what we're doing right now is waiting for the sky to fall and hope we can catch it before it hits the ground. That's a big but in the process. These are the kinds of things I'm warning you now that I'm going to take you through in my world that we're dealing with all the time. While, of course, everybody wants to give you a hug because you're wonderful. You get on an airplane and people say, hospice, oh, God, that's such fabulous stuff. My aunt, my uncle, my mother, my father. You go to a congressional office and they say, home health care. You know, my father just finished an episode of care. Rehabilitation was incredible. The people were just absolutely wonderful. And on the Medicaid side, I was so happy he could stay out of a nursing home. You know, I mean, that is all there, but we have some intense pressures going on in the industry. Now, here's the positive parts. For those of you who do home care, how many of you do some home care or hospice? You know, a few of you do that, and I'm going to do that. You guys are astounding in so many ways. but your ability to deal with these kinds of crises is beyond amazing. I'm sure that happens in other parts of healthcare as well, but home care has been bucking the world of healthcare itself for many, many years. I mean, institutional bias for long-term care and services, physician-oriented delivery of services rather than nurse-oriented services delivery, is a professional class itself. And hospitals, I mean, people don't donate to a home health agency to put their name on the building. They donate it so that they can get to a hospital. And actually, a quick little story on that one. Do you know Pat Sajak? Okay. Pat Sajak lives, or has a home at least, in Annapolis. His wife is from Annapolis. We live near Annapolis, Maryland. He and his wife donated a huge amount of money to have the name Sajak Pavilion on one of the local hospitals. And it was prominent along Route 50, which is the highway that goes through Annapolis in that way, until they put up a parking garage between his building and the highway. So poor Mr. Sajak doesn't get the notoriety that he once had. But last part of that story, we were at the Annapolis ice cream shop. And if any of you ever go to Annapolis, it's the best ice cream shop of the 50 within Annapolis, okay? Annapolis ice cream shop. Pat Sajak's in front of us in line, my wife and I. And the young women behind the counter look up at the people come from, and one of them starts saying, "Aren't you?" And he answers the question, "Yes, I'm Pat Sajak." She continues her sentence, "Aren't you Miss Dombi, the teacher from the Key School?" So this guy's already shrunk because his name can no longer be seen from the road on the hospital, and he's just been upstaged by a third-grade school teacher. And that way there, he just turned around, looked at my wife, and I was so proud at that point in time. Anyway, so this is the journey I want to take you through. It is a mixture of positive and negatives on the legislative and on the regulatory side. But Dave, this is what you asked me to do. If there's anybody to blame after you hear this, no, it would be Laura Fuller. Okay, all right. Let's start with the positive news from last year. The physician payment reform, just a quick note about that. Here's the positive part of that. The rest of healthcare is now out from underneath the annual threat for a physician fix, where they come to every other sector saying we need $5 to $10 billion. That's good, but two other things happen with this legislation that indicate where Congress is relative to home care, at least the home health side of Medicare. One was that they extended the rural add-on for 3 years, and we didn't have to pay for it, which is normally the way. Nobody but docs got money out of this thing except for that one thing. That wasn't a big piece, but it was pretty good to see that kind of favorable support. The other thing is we avoided a copay. And then Speaker of the House Boehner had a copay that was like the Obama copay in the bill, but Pelosi got him to take it out. And this was a Boehner-Pelosi kind of clash on the things, but she got him to take it out. This is about the 10th time we faced a copay threat since 1972, a serious one, but we've overcome that. We do see that as a very positive thing relative to choosing home care over other options and where Congress can offer some support. There are a list of things that you can look at on the handout on pro-home care and hospice legislation. I'm not going to walk you through that, but each of these are pro things in terms of trying to modernize it. Probably the most important one is to give nurse practitioners, physician's assistants, and other non-physician practitioners certification authority. I mean, it is beyond overdue. This is not a modernization of the Medicare program. It's just bringing it up to date. I mean, we're seeing hundreds of thousands of non-physician practitioners as the primary practitioner for patients in home care and hospice. And today, to get certification, you've got to hand the patient off to an MD who doesn't even know the patient. But here's a Washington story that'll curl your hair if it's not already curled. Maybe it'll straighten it if it is curled. And that is that the Congressional Budget Office may be the most powerful arm of Congress. We've been fighting for this issue for 10 years. We've got 200 members of the House and 52 members of the Senate who are co-sponsoring the legislation. CBO, we spent time with and convinced them that these non-physician practitioners would substitute for MDs. And since they're paid at 85% of the Medicare rate, it would actually save the Medicare program. We convinced them that their substitution, rather than when they first came into the conversation, they said, giving power of certification to more people means more spending. So we were able to convince them that nurse practitioners, for example, aren't committing malpractice today by ignoring a patient who needs home health and not handing the patient off to a physician. So we were so happy when that happened. Now, CBO's response in the end? Well, now that the doctors will not have to do this under this bill, because the nurse practitioners and other non-physician practitioners are doing this, the doctors will have more free time. And given that they'll have more free time, they'll find other things they could bill Medicare for. You know, we thought they might consider the doctors going to play golf, going out sailing, sitting around just watching The Price is Right, you know, on a Tuesday morning instead. But no, that's how CBO thinks. The doctors will now have free time, and it'll cost the Medicare program some more money. So all of these positive legislative pieces still have to find their way through CBO. We've got one thing going on in Medicaid that's worthy of note, and that is a push for electronic visit verification. This is a plus-minus kind of a thing. There is an image issue developing relative to Medicaid home care and time and attendance of personal care aides, both what we call consumer-directed care as well as agency model. One example, a person who was a prisoner in the California prison system was collecting in-home supportive services benefits. He would go out on a work release for purposes of getting recertified for the in-home supportive services benefits. He was not getting personal care while he was a prisoner. The system finally decided they had to match the list of prisoners with the in-home supportive services client list, because it turned out there were not just one there were many, many more prisoners who had figured out this little game. So electronic visit verification to determine, does the caregiver show up where the caregiver needs to be? In this case, the caregiver actually was his live-in girlfriend, not living in the prison. She was living in his apartment and that way there. But some of those kinds of things happening for electronic visit verification. Again, a program integrity measure that's coming in that we see a lot of value to, but we don't know whether or not it'll come fast enough to present a tainting of the image. On the hospice side of things, here's how we look at hospice. Any of you do hospice? Okay, here's how we look at hospice. All of those innovations you're seeing going on in the Medicare program today, hospice was there in 1983 doing all of this. Bundling, that is hospice. You know, integrated care, that is hospice. You know, outcome measures, that is hospice. You know, I mean, that has been there since 1983, yet the benefit now growing is under some pressure. Still some improvements necessary there, just as in home health, getting the non-physician practitioner with authority, taking care of some of the regulatory issues, like a face-to-face encounter has to be done if the patient goes into the third benefit period. But one of the number one burdens in Washington that hospice now has is the fact that hospice has become predominantly a for-profit industry. Home health has long been a for-profit industry. There are still not-for-profits affiliated with hospitals. There are still some VNAs around. When I started working in home health back in the mid-'70s, everything was a public health agency or a visiting nurse agency. Today, there are very few. There may be, if there are 200 VNAs across the country, I'd be surprised. Major cities, San Francisco, LA, Dallas, they don't have a VNA that provides home health anymore. You know, Michigan, there is a VNA of Michigan. I think that's there's a couple others in the state as well. So one of the burdens then becomes the label of for-profit often translates negatively on things. So we're trying to deal with some of these issues on program integrity and hospice as well. But the main thing that we're focusing in on the hospice side, and Congress's attention's there, the regulators' attention's there, the solution's just at this point elusive, and that is the pre-hospice needs. Those individuals who need some sort of palliative care, but don't fall necessarily into a nursing facility eligibility, don't fall into Medicaid for the means testing they don't qualify for yet. They're not eligible for the Medicare home health benefit, and they're not ready for hospice either, that palliative care aspect of things. And that's the big thing. And is that even a hospice service is a question that still remains out there. Who should be providing palliative care? But that's where we're seeing everything focused in Washington in the realm of hospice. Now here's one of our friends. How many of you do Medicare skilled nursing facility work? You know, most of you, many of you do that. And so you know MedPAC. And every year MedPAC says your skilled nursing facility payment rates are too high. You're making too much money, whether you're for-profit or not, you're too high, we're gonna take money. That's the place to be. Think about this, if MedPAC was recommending that your payments be increased, what do you think your financial status probably is? You're in Chapter 11, Chapter 13 bankruptcy already. So the fact that MedPAC's picking on you and home health and hospice is a good thing. It means you're still operating. MedPAC does not see any provider as being paid too little. It's always too much. So in the hospice and home health realm, MedPAC's recommending rate reductions. MedPAC's recommending rebasing in the home health sector, because here's what the margin is that they're projecting for 2016, 8.8%. So they said that's not enough. The margin should be 0 in MedPAC's calculation. So continued pressure relative to payment rates coming from that. And the same happening on the hospice side as well, pressure to reduce payment rates, to deal with a number of the program integrity measures that are coming out there as well. And the biggest issue for hospice today is the push by some places to have it be part of the Medicare Advantage benefit plan. Right now, if someone's on Medicare Advantage and they want hospice care, they're outside, they're back into traditional Medicare. And the question is, should it be part of the benefit package in Medicare Advantage? Our policy position is no. And our policy position is there informed by our experiences in home health. Our experiences in home health tell us you're going to get limited authorization for care. It's going to be delivered in a piecemeal rather than an integrated fashion. They're going to pay you less than it costs to deliver care. And then they're going to come in afterwards and take it back. And you're seeing that in Michigan on home health. At least one of the Medicare Advantage plans, one of the Blues plans, is contracted with a company called SCIO. And SCIO is retrospectively reviewing paid claims and saying you've got to pay money back, and not on the basis of necessity, but on the basis of technical paperwork kinds of documentation issues along the way. And they're asking for significant dollar amounts, well into the 6 figures for a number of providers of services. So we don't have a positive experience with Medicare Advantage with that. So from on the hospice side, we say, unless we can be assured we'll have a positive experience, we're going to have to oppose it. Now, this may be bigger than we can stop. And so we're then looking at saying a fallback position is that the plans must deliver hospice as hospice is today. Hospice is an organized, integrated, multidisciplinary team approach to the delivery of services with bundled payment. That's why it works. Instead of a Medicare Advantage plan saying, well, this person needs an injection of morphine, so let me find a nurse that we can send out there. Instead of having a medical social worker part of a team of people that includes the physician, the nurses, the therapists, and family members even sometimes, they say, well, we'll case manage the person, counsel them on the phone, and see where we can go with that. That is a cynical approach to Medicare Advantage, but honestly, with people who are in hospice, how many mistakes can you make? I mean, they're not exactly repairable mistakes. At the funeral, you'll say, I'm so sorry. We've retroactively looked at the decisions we made, and we were wrong, and so, should you come back to earth, we'll give you what you need for services. It's a serious area. And the other aspect is terminal illness prognosis. I don't know anybody who has, cornered the market on doing that accurately. That has got to be the toughest decision made in healthcare. And then the tougher part that follows that is to then the conversation with the individual where you say, we believe you're going to die in 6 months or less. And then, that has to be traumatic. I know both my parents, my sister went through that. And so I know that it was traumatic for them, and it was traumatic for the family as well. So that's the thing on hospice that we're watching for more than anything else, is to move there. Now, for those of you who might be partisan, frankly, we don't find a president, Democrat or Republican, that we could say stands out as more in favor or less in favor of home and community-based care or hospice services. They all say they love it. They all say they want it. Obama's grandmother was a hospice beneficiary in Hawaii before she died. And we've had other presidents who've received home health services. I don't know whether Medicare covered them or their own insurance company. So there's a lot of support for it. Bush was, the New Freedom Initiative, keeping disabled out of institutional care to the greatest degree possible. At the same time, Clinton was president when the Balanced Budget Act hit, which was a disaster for home health care under the Medicare program. So we don't know where the partisanship goes. We do know that both the Republican and the Democrat platforms this year say home care is a priority for health care for them. I don't know whether they can walk the talk in that way there. But Obama's budget for several years has had hits on hospice payment rates, home health payment rates, the imposition of a copay relative to the Medicare home health benefit, post-acute care changes all around, whether it be bundling or value-based purchasing along the way. So, you know, we just always hope that budgets like this are dead on arrival. What the next president brings is hard to say, but it's highly likely that if it's a President Clinton, she'll be looking at the last Obama budget and seeing what's on there. If it's a President Trump, then I don't know today where he would go, honestly. No, I'm sorry. I never try to be partisan. Frankly, I'm not going to say anything more. I could only get myself into trouble in that regard. But the president's budgets, you know, do set the stage, and the Republicans, you know, have looked at Obama's budget and say, if we can do things on a bipartisan basis, then we can do things great in that way, those kinds of cuts. Medicaid home care, what we're seeing nationally on Medicaid home care is a move towards managed long-term service and supports. It is, at this point in time, a projection that in 5 years' time, every state will have Medicaid managed long-term service and supports. We're still trying to figure out whether these plans will know how to do it. I mean, the first thing that we've seen so far is that we have two kinds of plans. One plan that sees the value of home care, and another plan who has no idea why anybody spends money on personal care. I mean, Medicaid spends a huge amount of money on personal care in the home setting, and these insurance companies, health insurance companies, come in and say, we've never done anything like that before. You know, paying for baths in the home? You know, I mean, this is not a spa at the Grand Traverse Resort that we're running. We're running a health insurance program. The reality, as you all know, is that the activities of daily living support is the main reason why people can stay safely at home. It's not the skilled care services alone that get people there. So the plans then start acting like insurance companies, which is, well, the first thing we need to do here is reduce your payment rates. These payment rates, which were probably lower than costs to begin with in Medicaid. Imagine this one here. You're in Michigan, you do a little bit better in Michigan than other places, but Texas pays $12 an hour for personal care. To pay a worker $9.50 costs a home care agency about $14.50. When you pay up workers' comp, you know, unemployment insurance tax, you pay your share of the Social Security side of it as an employer, you do the billing, you do the training, you do the oversight, you know, you pay for the travel time, because in that $12 an hour, that's in-home time, not time going from one home to the other, which you're paying for because that's work hours right at that point in time. So the workers then say, we need more pay, we need overtime compensation, and the state says, sorry, you know, we're not giving out any more money, and the managed care plan says the same. So we're seeing managed care moving towards long-term service supports quite heavily. Jury's still out as to whether it's positive or negative in that way there. First indications are we've got the positives and the negatives happening at once. We have definitely some really solid managed care Medicaid companies who see that doing the right thing in home care can pay dividends in their overall capitated payment. For example, arming personal care aides with smartphones that have a series of questions that are asked every time they go into the home that relate to the person's condition. I hesitate to say patient because they're not really patients in that way there. Observations that lay people can make that are put into a database to trigger potential nursing or physician intervention because you see changes in the condition. Those eyes and ears, those boots on the ground become effective monitoring approaches that could save a hospitalization, that could save tremendous amount of money in that way there. So we see a lot of positives on the Medicaid side, but still watching it. On the technical side, they've got a new rule called the Medicaid face-to-face encounter rule. Rule just came out this year. Michigan, I think, has until July 1st of next year to comply, requiring for home health services an encounter with the physician that is then documented. But a couple other things in the same rule is they've now formalized the elimination of the homebound requirement in Medicaid home health, and there's not a skilled care requirement like there is in Medicare too. It can just be home health aid services available. We do see a complete difference between Medicare and Medicaid CMS people on home health care. So here's some more of the aspects of that regulation. A couple of things that are affecting in an indirect way two rules which will affect you on the Medicaid side also for your nursing facility care, and that is the methods for assuring access to covered services, otherwise known as the rate rule. This has turned CMS into probably the best form available to you to deal with rate issues. Still to be tested out on that, but CMS sent a message to the states saying, we're going to be looking at your payment rates whenever you're adjusting them downward and potentially even upward to make sure that access to care is in no way burdened as a result of that. Now, will the next administration do that or not to be determined, but this current set of CMS officials has gotten tough with a number of states. The other one is the Medicaid managed care rule. In some ways, this competes with one parts of your business. This rule basically says Medicaid managed care plans have to give a priority to home and community-based services and have to justify why they're supporting care on an institutional basis. A presumption that people can be cared for in the home setting is the best way to look at this. Still no enforcement on it that we've seen so far to get a real understanding of it. On the Medicare home health side, this is where the busy stuff happens that we're talking about. Medicaid spends $70 billion on home and community-based care. Medicare spends $18 billion in home health and $15 billion in hospice. But most of the activity is around the Medicare side of it. We've got a proposed rule out there now for 2017. I'll be going from here to my room to work on the comments that are due tomorrow. If you've ever had to do regulatory comments, it's like a term paper. You know, you wait till the last moment to do it. It seems all the time in that way there. And then what you do is you cut and paste from some of my colleagues in the office who did other pieces of it, who do it in a different format. And I don't know how to work documents really well, but I have to figure that all out. But the proposed rules on what has effect on rates, but also in home health today, in 9 states, there is a value-based purchasing program in operation. Different than the one that's going into the skilled nursing facilities, more intensive than the one going into the skilled nursing facilities, and more impacting potentially financially. And we've got a number of things I'll talk about in otherwise on oversight stuff. The 2016 rates rule was where we first saw the value-based purchasing program. And we saw the typical rate rebasing results. We call case mix creep was hit, case mix creep upcoding on the episodic basis. You know, they find that coding increases, that means payment increases, and they say the patients didn't change, so we're going to try to take our money back. That's continuing to go on there. And then the 2017 rule is the last year of rate rebasing, and they're making a few changes in there, like on outliers, where they're trying to get much more refined on a cost outlier basis. The main reason for the outlier change, some home health agencies go into assisted living facilities and provide insulin injections to diabetics who can't self-inject. And nurses will do 10, 20, sometimes 30 visits in a day's time, but in terms of the outlier formula, a visit's a visit's a visit in terms of a cost. And that modality of service is extraordinarily profitable, because instead of having a $145 visit of cost, you've got probably a $20 visit of cost, but being credited in the outlier formula for that $145. You know, Miami really was the center place of all of this, and most have been put out of business, but now they would move to a 15-minute increment type analysis for a proxy for cost. We're not happy exactly with this. It is a refinement, because as you can imagine, in the businesses you do, you know how this works. Does the first 15 minutes cost the same as the second 15 minutes and the third and the fourth? In home health care, whether it's a 15-minute visit or an hour and 15-minute visit, you've got the travel costs to get there, for example. You've got the scheduling costs. You've got all of those other kind of costs. So we need to see these weighted is what we're saying along the way. On the value-based purchasing, for first on rebasing, we went into rebasing in the first year and said, you got to pull this back. The industry's going to go out of business. And this is one of those resilience examples. We projected that by now, 65% of home health agencies would be paid less than their costs. Somehow, some way, those in home health had the creativity to figure out a way to keep their head above water, and we're looking at about 35% of the providers, which is about the normal amount, who are being paid less than their cost for care. Somehow they found new efficiencies. I'd hate to say this, Dave, but some of them found it by stopping paying us dues. They decided to ride the coattails of other people in the work that we did. They saved money. They saved, I think our dues charge is something like a 0.001% of revenue. So, I mean, they saved a lot of money in doing so in that way there. But we don't see rebasing being curtailed back. MedPAC's recommending it again, but unlikely Congress is going to step in because this is where Congress is, this is where CMS is for home health. Value-based purchasing. The pilot, as I mentioned, is underway. 3 to 8% is at risk. First year, 3%, and over the 5-year demonstration program, it rises to 8%. It can turn into a death spiral. If you were to get 3% reduction in your revenues from Medicare or Medicaid, do you have the resources to improve your performance the next year? So if they want to incentivize performance, pulling away resources is not exactly the best way to go. But this is a carrot and stick approach. You can get bonuses for high performance as well. When I was a kid, my parents used just the carrot approach. We got paid for our grades. An A got so much money and a B got so much money. The equivalent to this program would be that if I got 25 cents for an A and 10 cents for a B, yes, I am old, 10 cents was a big amount of money back then. It could buy a comic book. The counterpart to this would be if I got a C, I'd have to pay my parents 10 cents, and if I got a D, I'd have to pay them a quarter. We don't, in this, it is that penalty and reward approach there. It's based upon a series of performance measures. Some are patient outcome measures coming from the OASIS system. OASIS is the patient assessment model in home health, a whole series of them, and then some process measures as well, and then a few reporting measures that they added to it. It is not a system where they take the money and put it into a pot and then divvy it up later on. Instead, it affects the rates in a 2-year period of time later on. But we are seeing in the 9 states where this is happening absolutely a behavioral change, because this is behavioral modification in the Medicare program. And you're seeing it not just in home health. You've got it in the skilled nursing facility side. The hospitals have it. The physicians are going to have it. This is where it's all going to go, because it was 20 years ago or so that then an official with HCFA, the predecessor to CMS, a few of you might remember that HCFA, hardly cares for anyone, or here comes further aggravation. Said to me, he goes, we're getting out of the business of buying home care visits. We want to buy outcomes. It took a while to get there, but that's what they're looking at now, is buying outcomes. Why I say it's a death spiral is because each year, you're going to see a section of the industry in jeopardy of closing. And say 5% of the home health agencies close because they've been penalized at a high level. Well, the next year, that 5% is gone. Somebody else has to be at the bottom of the 5%. And then each year thereafter, the same. This is happening on a state-by-state basis. Providers in each state are competing with each other and trying to get better performance. You could improve your performance in this model and still be penalized because somebody else improved their performance better. What we're still looking for is something like the Olympics. Usain Bolt can look around and see where his competitors are. The way this is operating now, you don't know where your competitors are. You can only really guess. You can see where they were in 2015, where you were positioned in the baseline year, but you can't see where they are in 16, 17, 18. They've got to change that model along the way. 3 to 8% at risk is far greater than the 2% the skilled nursing facilities have under their Medicare value-based purchasing. That, we don't think you need that much to change behavior, but that's what they're putting into the mix at this point in time. The measures that they chose, 2 problems. Risk adjustment in the home health measures is really bad. It really doesn't distinguish between providers based on their patient census well enough. But beyond that, they focus mainly on improvement measures. And I know the patient population you deal with is similar to the ones that we deal with in home care. How many of your patients are subject to some restorative rehabilitative therapy versus those where you're maintaining their function or slowing their deterioration down or making it a comfortable end of life? And so they don't have any of those types of measures in this system because they say there's not much variation in performance, and we need areas where there's variation in performance, so that's where they're looking at the improvement side of it. What we're concerned about is now discriminatory admissions into care, that the individual who may be a train wreck type person with multiple chronic illnesses, maybe dying, is now someone the home health agency doesn't want because it brings its scores down. They may provide absolutely incredible care, but not be credited for that. Is this a backdoor way of turning the Medicare home health benefit into a short-term, restorative benefit as compared to a much wider one. We have our views on that there well. So we're concerned about that aspect of the discrimination that might come from it. Congress is also weighing in on value-based purchasing, and those who do skilled nursing facility, pay attention to this one, okay? In September, the House Ways and Means Committee will come out with a piece of legislation, version 2, on their post-acute care value-based purchasing bill. It's a post-acute care value-based purchasing bill. It's not a home health or just a skilled nursing facility one. It's pulling us all together in this regard. Version 1, the performance measure was spending per beneficiary. I hope we don't end up with that as a definition of value. Version 2, we expect some more of the Impact Act elements to be brought in from a measure standpoint. I know you've got Impact Act discussions in your queue for your programming. This bill has the high priority within the Ways and Means Committee. Ways and Means Committee Chairman Brady is behind this bill. He's not the named sponsor, but he's behind this bill. And that way, as chairman, you don't come out as a named sponsor on things. But it's definitely something to watch. We're expecting that we're going to get a briefing on it next week on this. No one, to our knowledge, has seen the details of version 2. We have heard that they've made changes in it because the entire post-acute care industry, I was on a call just yesterday with our collaborative on this, is opposed to version 1. And what they're trying to do on version 1 is to add some sweeteners into it to try to convince people to support that. As a collaborative, we are in consensus that we will not be bought off by some little sweeteners if the core bill itself is still bad. But this is the state-of-the-art stuff that's coming down from Washington that's going to affect you in the nursing facility side, you in the home health side, we in the home health side, long-term care hospitals, rehab hospitals as well. And one of the big questions is timing. Is it sequenced with the Impact Act implementation, or is it done beforehand? The first bill was before Impact Act is actually pulled all together. It would happen that way. And then will it be budget neutral, or will it just take money that can go to some other place? But its design, as we understand it in version 2, is budget neutral. But that still ends up having impact because it redistributes monies all around. But then we expect more and more of that. I've pretty much mentioned all the concerns that we have. I suspect you would share them on the nursing facility side in that way there. Now a few Medicare kinds of issues to talk about. Face-to-face physician encounter. Those of you in the nursing home world are so lucky because you have nursing homes with physicians that come there. Not a lot of physicians make house calls, and more importantly, not a physicians like documentation. And this is a documentation issue. This came in as part of the Affordable Care Act, and the issue has evolved to a point where it has nothing to do with whether physicians have seen the patient. These are the certifying physicians. It has nothing to do, because they're seeing the patients. All the time they're seeing the patients. It has to do with whether their documentation is sufficient. And we have a situation now in home health where the physician has to have in his or her own file sufficient documentation to support the certification of homebound status and intermittent skilled care need. So you've got a circumstance where a party who has no vested interest in the outcome of the benefit determination has the responsibility for the documentation, and the home health agency carries all the risk of that documentation being insufficient. And I'd love to have a discussion with all of you as to the definition of insufficient, and I would imagine we would get quite a few different definitions. You know, am I sufficiently dressed today to show the respect that I have for you? You know, I don't know. What's going through your head now? They're saying, why did this guy wear a suit? Other people are saying, yeah, he wore a suit and he respects us for doing so. But I don't like his suit, you know, so it's not sufficiently dressed. And somebody else says, I don't even like listening to the guy, so I don't care what he's wearing. You know, nonetheless, that concept of sufficiency is highly subjective. Hopefully some of you like the way I'm dressed. You know, I worked on it, you know. I mean, I steamed my suit out of the suitcase last night in the shower. I did that one time. Those of you who travel know that you have to do this sometimes. I did it one time. I was in Providence, Rhode Island, and I think it was a Westin hotel, and I forgot that I left it in the shower. And I opened up the door to the bathroom like 3 hours later, all right? And the walls are, it's like the tropics, beyond the tropics. It's like the Amazon on the walls in that way there. And I said, oh, God, so I rush. I turn the whole thing off. My suit is like, ugh, and that way there. And then the fire alarm goes off. Yeah, I didn't put two and two together. I set the fire alarm because of all the heat that was coming out of the bathroom. Next thing you know, they're evacuating a 24-story hotel. The next day, I get a note from management saying, for future reference, we have a service that could take care of your suit. And Dave, you might, Dave, you might like this, the second part of that, which was the next hotel I went to was for one of our own conferences there, and I'm checking in, and the person's looking at the screen and says, Mr. Dombi, were you recently at the Westin in Providence, Rhode Island? She was set up to ask that through our meeting planner. Okay, so anyway, the face-to-face encounter has gone through multiple generations of problems. We filed a lawsuit on this. We got them to change the documentation requirements and the regulation through the lawsuit. They went from having a physician narrative requirement to this physician in the record, file record thing, which has led to a probe and educate audit where 8 out of 10 cases that were reviewed. Every home health agency had 5 claims reviewed for this. 8 out of 10 were rejected, which from our end of it says this is an unmanageable policy. You've got the entire industry trying to do perfect work on this thing, and they're failing. There's not some sort of massive dumbness in the industry. You know, something's wrong with the policy. It's an unmanageable policy. We are still trying to work our way through this, and now these face-to-face issues have become the centerpiece for these pre-claim review cases as well. So serious kinds of concerns to there that are still documentation. You know, I say the following. If I had to keep that number 2 pencil within the bubble on those multiple choice questions when I took the SATs and when I took the LSATs and when I took the bar exam, I wouldn't be here today. I know my pencil had to stray outside that bubble. But this is, you've got to be perfectly within the bubble. You know, perfect documentation, also with a subjective standard that you just don't know. Some of the other things, traps that are out there, you have to have on a form. The rule didn't change, but the policy did. You have to have on a plan of treatment that I certify that in my estimation the services will be required for blank more time. If that's missing, the entire claim is denied, just for that failure to have that one little piece on there. So you can imagine these little machines at the Medicare contractors, you know, scanning for this there and hoping that they could find it's missing so they could deny the claim. You know, $3,000, home health claims are $3,000 to $5,000 for each episode. So it's not a small hit when that happens. Medicare Advantage post-pay audits I mentioned before. If you see the acronym SCIO, SCIO, whatever it is, run because they are out after money. And the Medicare plans themselves are being, have SCIO coming to it and saying, here's a menu of all the things we can audit for. You pick the ones we want to take. And the things that they're going after are technical documentation issues that the providers did not even know applied in a Medicare Advantage context because they thought, well, this is Medicare Advantage, not traditional Medicare. We don't have to do the same paperwork because you're giving us prior authorization. And now the plans are pulling it out and saying, no, these Medicare fee-for-service, traditional Medicare paperwork requirements apply as well. And they've got something somewhere on their website in their provider manual that says we follow the Medicare, original Medicare standards. But they don't have the specificity on these kind of things, and people operated for years without seeing that happening. So serious kinds of issues that are there. Some Michigan providers are challenging this. CMS home health star ratings, just a couple of words on this. Can you imagine how mediocre everybody would be, every hotel would be if they're all 3-star hotels? That's pretty much what home health is, all 3-star home health agencies. Because they built a model that does not have objective rating. They have a model that's a bell curve type approach, and everybody ends up grouping around the middle. You know, and now we're seeing some of the payers like Medicare Advantage plan out in Washington State saying we'll pay you based on your star rating. You're a 5-star home health agency, we'll give you 105% of our normal rates. If you're 4-star, we'll give you 85%. If you're 3-star, we'll give you 75%. 2-star, 70%. Doesn't seem to care about quality because they just want to pay less, right? There isn't a 5-star agency in the state. And if you know home health fraud and abuse at all, you know that Miami is the epicenter of that. There are more 5-star home health agencies in Miami than anywhere else. Why? They found a way to manipulate the star rating system too. So nobody in Oregon and Washington State and a whole bunch in Miami, it should tell you something, but the star rating system is misinforming consumers. We know the skilled nursing facilities have problems with their star rating system too. It's bad enough that it misinforms consumers, but then when Medicare Advantage plans can start taking advantage of it too, is bad. Post-acute care bundling, much going on that affects you all. Our home health agencies have not been engaged in it as much as they should be. They are not putting skin in the game. They're not at the table the same way as they should be, but are we hoping that this may change along the way? Early indications are that the use of home health services saves in the bundling and brings rewards to providers of services. But we do expect to see more and more bundling, the joint replacement bundling going on now, the CJR bundling, and you have some in Michigan where this is happening. We see this as a very pro-home health care change that is not yet materialized as well. Instead, what we found is the doctors who were collaborators are saying, we like home health and we're going to order home health, but we want nothing more than a LUPA episode. Doctors who had no idea what a LUPA episode before was now know it, and you probably don't know what it is either. LUPA is low utilization payment adjustment. Instead of paying $3,000 for an episode, you get $150 for each of the 4 visits approximately, so you get $600. So the doctors are ordering no more than 4 therapy visits because $600 helps a lot in keeping it below the target price and ending up with some gain sharing along the way. We're going to see more and more of this. We're still debating where we are with the next proposal that they have on bundling, the one that has those 3 different areas on that. Still questioning whether or not. Pre-claim review, I've already given you all the depth on this one as well. Here's what I need you to do, okay? If you pray. If you are into yoga and you want to get the world clean, follow this as well. If you just wish best tidings to everybody, do it on behalf of home health too, that it goes away before it comes into Michigan on January 1st, because it will be an absolute nightmare for Michigan, and it is very likely that if it continues the way it's going in Illinois, and this is with nothing but pure somberness on this, we would expect to see half of the agencies close in Illinois if things don't change very rapidly. You can't have 7, 8 out of 10 claims denied payment when you've incurred the cost. It's not a matter of being able to avoid the cost. You've incurred the cost by the time they make the pre-claim determination. At that point in time, where do you get the revenue to cover your staff? I mean, so cash flow disappears, then your staff disappears, then your organization disappears, then home health disappears. Now, some of you may then pray, say, good, then they'll all come to my skilled nursing facility, but you know that's not the best place to be. Hospice developments, I can sum it up pretty quickly. We're getting close to the end of time here. I personally love hospice. As I mentioned earlier, 3 of my family members and a 4th, my mother-in-law, was on hospice. But it is a benefit that took a long time to mature in the eyes of regulators and in the eyes of Congress. It started in 1983, but it's only now, the data is being sought to even understand what is going on in hospice. Until just a couple of years ago, they had no idea, and we had no idea, what was being delivered in hospice. How many nursing visits, how many therapy visits, what kind of drugs, how much in terms of pharmaceuticals, what else was going on in hospice. We had barely any information even about the patient population. How many are cancer versus non-cancer diagnoses? Very little information, and now it's matured in that regard, much, much more data being collected. And when more data is being collected, it does provide the means to bring about reforms. And we do see hospice baby step-wise being reformed. Best part of that, it's being reformed very cautiously. As I mentioned earlier, people don't want to make mistakes when dealing with terminally ill patients, and you can make a mistake in restructuring what the hospice program looks like. There was a baby step taken last year, which was to change the payment model from a per diem payment model where each day of service was paid the same. If you were in the home setting, paid the same. If you were doing short-term hospitalization, paid the same, no matter which day in the care. Concerns came about because the hospice benefit of 6 months or less to live really isn't an absolute. You could have patients on hospice for several years. It does happen that you could still be considered terminally ill even if you're alive after 6 months. My mother-in-law was told, we were told she was terminally ill when she entered a nursing facility. And my wife with power of attorney didn't choose to elect hospice on her behalf at that point in time. She did elect hospice eventually for her 9 years later. She had Alzheimer's or some form of dementia. She really looked end stage from my Juris Doctor, skilled position when she entered that nursing facility. She lived 9+ years after that. She was on hospice in the last 30 days of her life. We have a lot of patients on hospice on for 2 to 3 days, and many others on for months. And that payment on a same-day basis kind of thing was failing to recognize that that patient on service for a week had a very expensive week for that hospice. The admission and discharge, intensive amount of services during that period of time, as compared to the one who's on for 9 months, where you can spread out those fixed costs, those administrative costs along the way, and you're not having the same volume of visits all in that period of time. So they went to a new program of separating the first 60 days from the next days thereafter, 61, a baby step. We may see further reform in the coming years, potentially even a case mix adjustment model. We do believe there's going to be a deliberative approach to get there on an evidence-based approach so that it is not prematurely changing the program, but since there is a wide range of patients within the system, something does absolutely need to change in that way. You don't want to incentivize acceptance of long-stay hospice patients any more than you want to disincentivize acceptance of long-stay hospice patients. How do we deal with the individual who's in a nursing facility? We've got a bias at MedPAC where MedPAC says, well, these people are cheaper when they're in a nursing facility because there's several of them in there and they can minimize the kind of cost, no travel time and seeing all these patients. Well, that's not always the case. Sometimes it's one patient in a nursing facility. Sometimes that patient's requiring more intensive care than someone in their own home. And so the residential location should not be the determinant that way. But those are the kinds of things that are coming up along in hospice. At the same time, we're seeing concerns on the program integrity side. Key TAM lawsuits under the False Claims Act, audits of home health agencies by Medicare itself have been on the increase. And that 2020 hindsight, wait a minute, you said 9 months ago she was terminally ill. Clearly she's not, she's alive. So you were wrong to start with. One big case that's pending before the 10th Circuit Court of Appeals is a False Claims Act case involving AseraCare, one of the national hospice companies. And the issue that's presented there is, can the government support their prosecution based upon an outside consulting physician who reviews nothing but clinical records after the fact, compared to the opinion of the treating physician, the opinion of the interdisciplinary team relative to the terminal illness status of that. This is a major case in healthcare overall in that regard, and I think you can recognize it. Who do you think is in the best position to assess the condition of the patient? The treating professionals, or somebody who's sitting in a room without any windows and has a pile of paper in front of them and going through that in 5 to 10 minutes? We know that that's not the best way, particularly with 2020 hindsight, on a terminal ill question for individuals there. So for reading pleasure tonight, I saw your schedule has you free for tonight. You might want to read the rule. There were several other links I gave in here. I tell you, I'm going finally to have a vacation this year after Labor Day. I am taking the Federal Register with me. It is the best way to have beach reading. That way you fall asleep really quickly. So some changes in the hospice rule, payment changes that are there, minor kind of changes this year. New measures coming in on the data side of the hospice end of it, moving towards patient experience information and stuff. This is still going to take a few years to get out there, but this is the clue that we get about how we expect to see some reform in hospice along the way. There'll be public reporting in hospice, a hospice compare, like you have nursing home compare and home health care compare. There will be a hospice compare probably the summer of 2017. Couple last closing points. The overpayment rule. We have that issue in home health. You have it in a skilled nursing facility. You have it in your Medicaid side. You have it in your Medicare side, identifying an overpayment. There was a settlement just reached for a hospital today that was announced yesterday that's paying back 3 times as much as they identified as overpayment because they didn't repay it on a 60-day period of time. And this is a potential potential 10-year window of looking to see whether or not there's an overpayment. And you're not under this rule in a position to say, well, I won't look, so I'll never find an overpayment. You've got a responsibility to be reasonable in terms of your oversight internally as well. So definitely something to watch that we're seeing there. Closing remarks, the Fair Labor Standards Act in the Department of Labor has become a big issue in home care. It's not an issue in the nursing facilities. You know, your workers come and go. You can have a time clock even that way. I punched a time clock for several years in the summer during college time. I worked in a factory. And then I ran it over with a forklift accidentally one time, and I was the hero within that entire factory because I ran over the time clock. I was embarrassed at first, but then they're carrying that on their shoulders early that day. Fair labor standards, the issues in home care are about hours worked and whether or not the individual is entitled to overtime. When looking at this, I'll just give you a quick summary. Some cases, sleep time is reimbursable. Sometimes it's not. It depends upon whether or not it's a live-in, a shift worker, or somebody who just sleeps on the job. Travel time, by and large, is hours worked, but not always hours worked. Break time, depends on how long the break is. On-call time, depends on how much freedom there is. I mean, you are asking home care companies to become experts in the Fair Labor Standards Act, which means law firms are happy that this is there, and our other law firms, if you do like I did, which is watch TV at like 3 o'clock in the morning one time, you'll see ads on there saying, do you work in home care? Do you think you've been fairly paid? Was your overtime what you deserve to get? If not, call 1-800, we'll file a collective action on your behalf. A class action type lawsuit. There are some very hungry lawyers out there in law firms that specialize in that, going after home care companies, and honestly, they're succeeding, counting those hours. So if you're doing home care, here's where we are, Dave, at this point. There's not a single person in this room who wants to now get into home care, right? In any capacity. Now, if you want to, here's my closing remark in the areas. Moratorium. The Medicare program has established moratoria in a number of locations that go back a few years. Miami was the first place, then they went to Dallas and Houston, Chicago, and in the Detroit metropolitan area. They later added Fort Lauderdale area. As of July 29th, they've made those moratoria in those locations statewide. You cannot create a new home health agency in the state of Michigan at this point. You can buy a home health agency that already exists, a full change of ownership, but you cannot create a home health agency that does not currently exist. You cannot add a branch office to an existing home health agency in the state of Michigan. This is labeled as a 6-month temporary moratoria. Well, so were the other ones that go back 3.5 years that are continuing today. Best prediction is this is going to be renewed after 6 months. So if you're looking to get involved in the home health business after hearing that you've got pre-claim review coming down the pike, rate threats going on, other kinds of oversight, then you're going to have to go out and acquire a home health agency. There are plenty of home health agencies in the Detroit area that probably would like to sell because they're under a lot of heat in there. I would be very careful in buying some of these home health agencies, honestly. The due diligence would have to be absolutely intense on some of these. Not that they're fraudulent, but there are a lot of warning signs that lead me to say that. If you choose to acquire a home health agency, keep in mind something called the 36-month rule. If a home health agency changes hands within 36 months, it can't change hands again within 36 months and have provider enrollment take on that provider agreement. It's really a 24-month rule. Because you have to have you can have 2 full years of cost reporting. There are some other exceptions if you're doing the acquisition. The best one is this. If you acquire a holding company that owns other corporations that include a home health agency, that's not a change of ownership subject to the 36-month rule. But Dave asked me to give you a few remarks about that. Anybody who wants to talk further about that, I'll take some questions after that. But what I just wanted to close with is to thank Dave, thank Laura, thank Stephanie and all the staff from LeadingAge, for the opportunity to come back here to this wonderful place of Traverse City. My wife has adopted it as a home she'd like to have. She never will. We flew to Grand Rapids yesterday. It's not easy getting to this place sometimes. But I'll end up on Sunday afternoon at the Michigan 400 NASCAR race. Someone's invited us to join them. It's not that I'm a NASCAR fan, but I do enjoy cars, actually. And I'm looking forward to smelling that fuel permeating my lungs to a point of terminal illness, maybe. I don't know. But again, thank you for that opportunity, and thanks for the opportunity to bring some part of what home care is to all of you. It is a wonderful place that I've lived for so many years, and that way intend to for quite a few more in that regard. And I'll be with you tomorrow as well, so thanks for that opportunity. Appreciate it.